Good morning, everybody. Uh, I'll be talking a bit on contact lens practices and its role in corneal ectasia and complications. Mr. Lasanta gave a very thorough and a comprehensive discussion on uh, contact lenses, so I'll be more or less adding on top of that. Mm, So, Mr. Asanta as Mr. Asanta correctly mentioned, lenses basically neutralizes the eye, providing providing an providing an front surface to the cornea. Okay, so it basically provides artificial front surface to the cornea, and neutralizing the eye. So concept dates back to Leonardo da Vinci. He is the one who initially came up with the idea, and by around 1950, PMMA lenses emerged, and nowadays we have like hybrid lenses. I think are the latest ones. So as Mr. Dasanta mentioned, indications are mainly optical. You could use for anisometropia, aphakia, high myopia, ectasia, and astigmatism. Other than these optical indications, there are some therapeutic indications as well, like corneal diseases such as bullous keratopathy, filamentary keratitis, erosions, and some of the non-healing ulcers. Then it could be used in aniridia, albinism. In those conditions, it could be used as therapeutic contact lenses. So there are some preventive indications as well to prevent the symblepharon formation, to prevent the exposure keratopathy and trichiasis. Those could be used. And for diagnostic purposes also, these contact lenses come in handy. So in ERG, fundus view, 3-mirror, gonioscopy, all these carry a contact lens. So when you're doing surgery as well, it is of use when you're doing vitrectomy, when you're doing goniotomy and laser. All these indications are there, and cosmetic indications are also there, such as in thicical eye and corneal scars. So basically, contraindications, there are no like hard and fast rule on these. It's basically common sense. Like you cannot really put a contact lens in an infected eye. Okay, so if there's any acute infection or an inflammation going on, you should probably avoid contact lenses. Other than that, all the contraindications are relative. Okay, so you should assess the patient's motivation, patient's mental competence, and I'll talk further on this topic in assessment. Okay, so and you cannot really use in age extremities as well. So there are some workplace related contraindications as well, such as when you are working most of the time in polluted environments, you better avoid the contact lenses. And environment with chemical products and dry atmospheres, you should probably withhold contact lenses. So this I think Mr. Dasanta spoke on. Why do we use contact lenses for optical purposes rather than the spectacles? So it provides a normal field of vision, and peripheral aberrations are not there, and no distortions, no fogging, and it's also some of the time cosmetically more acceptable as well. So it could be divided according to the manufacturing material. There are PMMA lenses, soft hydrogel lenses, rigid gas permeable lenses, like that. And depending on the anatomical position that it goes and sits on, you could divide the contact lenses as corneal, semiscleral, and scleral. And according to the mode of wear also, you could divide them as daily, extended wear, or disposables. So I'll talk briefly on some of these aspects that are important in contact lenses. So there are some words such as water content, oxygen permeability, and wettability. Some of these aspects are questioned in exams. So what is water content? Water content is is an indication of oxygen transmissibility across the contact lens. So there are pores in contact lenses. These pores absorb water, and if you have more water, your oxygen transmissibility is high. You just keep that in mind. And then there's this concept called wettability. So what's wettability? It is the adherence of a liquid to the surface of a solid despite the cohesive forces that hold the liquid together. Okay, so the wettability is a property of the surface, okay, that expresses the adherence of a liquid. Okay, so you are calling about a wetting angle. So when the wetting angle is high, wettability is low. Okay, like a nelum collate watura damma wage, it the watura binduwa goes and sits on the nelum colle, creating a bigger angle. Okay, so the wetting angle is high. That means in turn wettability is low. Just bear that in mind. So the other aspect is oxygen transmissibility. So it's the quantity of oxygen that passes through the contact lens. Usually it is better if the oxygen transmissibility is high. So in this formula you could derive that it equals to the coefficient of diffusion and coefficient of solubility divided by thickness of the contact lens. Okay. And so these are hard contact lenses, are made from PMMA, and you could understand that oxygen permeability is 0. Okay, it does not transmit oxygen, and it resists wetting, but it has higher optical quality, and it is stable, and it has excellent molding properties, and those are cheap as well. RGPs are made from cross-linking of silicon and PMMA. It has a good oxygen permeability, unlike with hard lenses. So RGPs come in handy when we are faced with a case of high astigmatism, irregular astigmatism. RGPs are the contact lens of choice nowadays, but it's kindly shifting towards mini sclerals now. So when there's regular astigmatism more than one diopter, irregular astigmatism, difficulties manipulating hydrophilic lenses, and post-surgical, post-PK in ectasias, you could use RGPs. Soft contact lenses are in turn made from hydrogels, and fitting is really easy, but it's very delicate, and it could rupture very easily, it cracks easily. And usually it's not used in high astigmatism. So soft contact lenses come in handy in these circumstances. When hybrids are against silicon hydrogels, and it combines the oxygen permeability of silicon with the hydrophilic hemo molecules. So I'm not going into details of these, and this is quite important. Contact lens assessment. So how do you select a patient, and how do you assess a patient when you are planning to put a contact lens on him? One thing is history. So we have to listen to the major complaint, and if there are any concurrent allergies, and systemic and topical treatment, and past medical histories of importance. And ophthalmic history, spectacles, and any surgeries and surface diseases. So ophthalmic examination is of very importance. You have to have a look at lid and adnexia, whether there are any entropians, ectropians. These are common sense, right? Horizontal iris diameter, the quality of blinks, the quality of tear film, puncta, conjunctiva, cornea, and of course IOP. and you have to question them on reasons for interest. Okay, so you have to assess the motivation level, as Mrs. Dasanta mentioned. So, and his psychological status, his working environment, his manual dexterity, and financial burden, and all this should be taken into account when you are considering a contact lens for a patient. I'll stop here briefly and talk about complications here. Can I have the next presentation, please? No, the complications of, no, that's not the, yeah. I'll talk briefly on complications of the contact lenses. Basically, it's when you are putting a contact lens, it is a foreign body sitting on your ocular surface. So it induces all the foreign body reactions, and it interferes with your tear film distribution, and it impairs corneal oxygen delivery. Because all these problems, you tend to get complications. So complications happen at different levels. You could get conjunctival complications, epithelial complications, stromal complications, like that. So I'll talk about the complications in a, like, I'll talk about common complications first. So deepithelialization is a very common scenario that we encounter in regular contact lens users. Contact lens alter the morphology and physiology of the epithelium and influences its integrity. So you could get punctate erosions, you could have Dellen formation, vacuoles, mucin balls, those things. These are mucin balls, okay, after contact lens, after like prolonged contact lens, yeah. And you all know that this is a Dellen. That has happened after contact lens. Dellen happens, you all know, like it happens due to poor distribution of tear film. So what should we do to manage deepithelialization? You have to monitor them closely, and not always. Most of the time, you'll have to stop wearing the contact lens, and you may have to treat with prophylactic antibiotic depending on the situation the patient is presenting, and you may have to refit again. So you could get corneal edema. This is also a very common scenario that we come across. It happens mainly due to hypoxia, and when it happens because of hypoxia. So when you are selecting higher oxygen permeability contact lenses, this could be prevented, and fit and wearing time also matters. So hyposthesia is another common problem. Like I said, it induces a foreign body reaction. So with time, metabolic changes occur, and they affect corneal nerves, and it desensitizes the corneal tissue. So with time, you could have hyposthesia. Okay. So sometimes patient come with like මට කලින් දාන්න අමාරුයි දැන් එන්න ලේසි කියන එක. So that's not a very like reassuring symptom. Okay. That's because of hyposthesia. We don't really feel happy about patients tolerating contact lenses in that. So 3 and 9 o'clock stain is a very common problem with hard lenses. So 3 and 9 o'clock stain, in the sense you have these 3 o'clock and 9 o'clock epithelial erosions in the cornea. This nobody knows why this happens exactly, but it is supposed to be due to poor tear film distribution. This happens due to hard lenses. It does not, like this. This staining does not. How do you say that? This happens outside the area that is covered by contact lens. Okay, that may be questioned. 3 and 9 o'clock stain happen outside the area that is covered by the contact lens. And then you could have conjunctival changes. This giant papillary conjunctivitis is a very alarming sign that we come across, and allergies are pretty much common. Allergic conjunctivitis, it responds to antihistamines easily. This superior limbic keratoconjunctivitis is not a very common thing, but this giant papillary is we usually come across. This is giant papillary conjunctivitis. I'm not going into the details. This is SLK, superior limbic keratoconjunctivitis. So you could get endothelial changes due to hypoxia and accumulated acidosis. Okay, so when your oxygen supply is cut off, your endothelium suffers, and as a result, you could get polymycethism, pleomorphism, and endothelial bleb response. This endothelial bleb response is it's not a chronic one; it's a very acute response. Like if you are putting a contact lens for the first time, the patient gets a bleb response within an hour or so. Okay. You get bleb-like swellings of the endothelium on the endothelial side, bleb-like due to acute hypoxia. This is not a chronic one. This polymycethism and pleomorphism are chronic situations. So the devastating condition is keratitis, microbial keratitis, infections, ulcers. Okay, so the risk factors are prolonged overnight use, poor hygiene, of course, and solution problems. So the pathogen, the main pathogen, the commonest pathogen is Pseudomonas. Okay, and then comes Staphylococcus and Streptococcus, and Acanthamoeba is like the main causes for Acanthamoeba keratitis is contact lenses. Okay, so when you see Acanthamoeba keratitis, it's almost always due to prior contact lens wear. It does not mean that contact lenses wear, contact lens wearers get Acanthamoeba commonly. The commonest organism is Pseudomonas. Okay, when you come across Acanthamoeba keratitis, it's almost due to prior contact lens wear. And this is a Pseudomonas ulcer, and this is a Acanthamoeba ulcer, classical ring pattern. Yeah. I'm not going into details on how to manage this microbial keratitis. You have to bear that in mind that the moment you see microbial keratitis, you have to stop the contact lens, you have to take the contact lens out and refer to a proper station. Then corneal warpage is also a condition, but we don't really come across. Do you see often warpage? No. I have seen only 2 cases for the last 5 or so years. So this is called pseudokeratoconus. It happens due to prolonged contact lens wear. It induces astigmatism just like keratoconus. Okay, and this thing topography picture is more or less similar to that of keratoconus. And how do you differentiate this? Like in keratoconus, are all of you module 2 trainees? How do you differentiate? Like how do you differentiate warpage and keratoconus? it, this looks exactly like keratoconus, usually in both eyes. So in keratoconus, in pachymetry, epithelial map, uh, in the areas where the stroma is thin, stroma is affected, it is compensated by epithelium. Okay, so when the stroma is thinned out, epithelium is thickened in keratoconus. Okay, the reverse happens with Wolfach. Okay, that's the usually only investigation sign that we could differentiate this from ectasia. And then lens related complications are there, the deposits, damage, and discoloration. So complications, do you have any questions on complications? I was just rushing through this. This is not a very comprehensive talk. Do you have any questions? Sorry? No. No, no. After removal, it does not progress. It doesn't progress. Yeah, you see Wofage, you discontinue contact lenses, it does not usually progress. And so, how's my time? Do I have? Do I have more time? Make you right? I'm there. Do I have more time? Excuse. No, I have another presentation on high astigmatism. Right. Yeah, then do you have any questions on my talk? No. All that. Okay, then thank you very much.